sir.
How are you?
I'm fine, sir. How are you?
Sir, good evening, sir. Dr. Das here, sir.
Hey, how are you?
Fine, sir. Fine, sir.
Good to hear.
Good evening, Dr. MBA, sir. Deep this side from RPM Product Manager. I hope all is
How are you?
I'm good. Thank you so much, sir.
You will be beginning the meeting.
Yes, sir. Along with me, sir, we have Dr. Roshan also, sir.
Good evening, sir.
Hi, good evening, Dr. Roshan. Do you have slides? Dr. Roshan?
No, sir.
I
No,
will
sir.
just
This
give
time-
a brief introduction and hand over the session to you. Fine.
Absolutely. Dr. Satyaranjan, after I introduce you, you will be the first speaker.
Yes, sir.
Do you have slides?
Yes, sir. I have slides, sir. I will try to open it from here. Otherwise, I have already sent it to Kalpesh so that you can do it from there if there is any technical challenge.
Yes, sir.
meanwhile, can I just check if my I can share my screen and
Please do so. Kalpesh, can you help her?
Yes, please.
okay. Is this visible?
Yes, perfect. Yes. Make it full screen.
The scroll.
Yeah. Perfect. Works well.
Thank you. Thank you so much.
Then Dr. Shilpa Gupta, then Dr. Gunjan, then Dr. Purva, and then Dr. Aditi. I'm sure all of you have slides, so one after another we can. If you all are free, then if you can be there for this lecture. After that, we have some question answer session. Those of you who can be around, it will be wonderful.
Shall we begin, sir?
Yes.
Dr. Roshan, can you open your camera? Can you control? Yes. So please start in 3, 2, 1. Please go ahead.
Good evening, all. Hello, I am Dr. Roshan Pawar. I am Head Medical Affairs from Alchem. I would like to welcome you all to today's experience sharing session on Romiplostim for ITP and the management of CIT. So, I will, before introduction to our today's monitor, I'll just quickly take you through the Alchem's entry into biosimilar. So, Alchem has fully indigenous development of biosimilar, and we are sciences, which is dedicated biologic manufacturing. And with great pleasure, we are proud that we have already launched our first two biosimilars, Romiplostim and denosumab. And we are also taking few of these molecules for our global development. So, and we are dedicated to 10 patients. So, with this background, we like to welcome our moderator for today's session and program coordinator, Dr. M.B. Agarwal, sir. So, Dr. M.B. sir, of course, doesn't need any introduction. He is professor and head of department at Bombay Hospital, and also he is consultant hematology at Lilavati Hospital. So, welcome, sir. And to start this session, I would like to hand over the session to you. So, over to you, sir.
Thank you, Roshan. Good evening to one and all. Today, the webinar is on experience sharing regarding Romiplostim in immune thrombocytopenic purpura and chemotherapy-induced thrombocytopenia. This webinar is brought to you by Mumbai Hematology Group. It is supported by Alchem and managed by Perfect Square. I thank Mr. Abhishek Bhavsar and their team from Alchem, Mr. Yash Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, our guest speaker of the day, Dr. Cindy Nunat from US, our Indian faculty who are very eminent hematologists, and you participants for sparing your Friday evening. We will introduce Dr. Cindy Nunat a little later after the first part of this webinar is over. Our discussants today include Dr. Ashish Dikshit from Manipal Hospital, Bangalore, Dr. Dinesh Bhurani from BLK Max Super Specialty Hospital, New Delhi, and Dr. Ganesh Jaishetwar from Yashoda Hospital, Hyderabad. In the first part of this webinar today, we have the Indian experience with Romiplostim in ITP and CIT. I'll be moderating this part. The panelists are Brigadier Dr. Satyaranjan Das, Dr. Amita Mahajan, Dr. S.P. Verma, Dr. Karuna Kumar, Dr. Shilpa Gupta, Dr. Gunjan Lone, Dr. Purva Kanvinde, and Dr. Aditi Shah. Brigadier Dr. Satyaranjan Das will be our first speaker. He's director at JP Hospital, Noida. This will be followed by Dr. Amita Mahajan from Indraprastha Apollo Hospital, New Delhi. Dr. S.P. Verma from King's College, Lucknow. Dr. Karuna Kumar from Yashoda Hospital, Sikandarabad. Dr. Shilpa Gupta from Holy Spirit Hospital, Mumbai. Dr. Gunjan Lone from Wockhardt Hospital, Nagpur. Dr. Purva Kanvinde from Vijayawada Hospital, Mumbai. And then Dr. Aditi Shah from KEM Hospital, Mumbai. So with that, it's my pleasure to invite Brigadier Satyaranjan Das as the first speaker of the day.
Sir, thank you very much, sir. I'll just share my slides, sir. My slides are visible, sir?
Yes, they are visible. Yes.
At the outset, I want to thank Dr. M.B. Agrawal, sir, for giving me this opportunity. I will be presenting 3 cases quickly, and these all are in my new appointment in Noida. They are the recent cases. So coming to the first case, this was a 56-year-old lady, known case of diabetic and hypertension for 10 years, and she presented with 4 to 5 purpuric spots. And there was no history of any fever or any non-steroidal anti-inflammatory drug intake. There was no other bleedings. Initial evaluation at a local hospital was suggestive of severe thrombocytopenia, and she was rushed to JP Hospital. She was admitted on 24th April. She was afebrile, she was obese, vitals were normal. There were multiple purpuric spots in the trunk, thigh, and mouth. CBC showed a hemoglobin of 12.2 gram %. Total leukocyte count was a little higher side, that is 18,690, and platelet was 5,000. KFT, LFT, PT-APTT, D-dimer, serum fibrinogen, ANA, and virology were negative. So patient received 1 single donor platelet transfusion in the emergency itself and was shifted to ICU. Then hematology consultation was asked for. So once we saw the patient, we did a bone marrow. The trail was cellular. There was adequate megakaryocytes. Bloods were 4%. There was no dysplasia, and flow cytometry didn't identify any abnormal cell. And biopsy was also cellular with increased MEX, and chromosomal analysis, which came later on, was 46XX. So her diabetes status was uncontrolled. RBS was 198 and HbA1c was 11. She was very anxious. In spite of on antihypertensive drugs, blood pressure were higher. So with the diagnosis of acute ITP, we managed with IVIG infusion 1 gram per kg per day into 2 days, and tablet tranexamic acid. Platelet started improving. On 28th April, platelet was 1,71,000 and discharged. Subsequently, on 3rd May, the platelet while she was at home was 1,20,000. Then on 11th, again the platelet was 10,000. There was a panic in the family, and she got admitted to JP again. And this time also, in spite of insulin, her RBS was high. So that time we discussed with her and started on Romiplostim 250 micrograms subcutaneously weekly. After 4th day, platelet improved, and on 7th day, platelet was 22,000 and she was discharged. Then we routinely follow up. By around 30th day, it was 1,54,000. Then we made Romiplostim 250 microgram once in 10 days. And then on 45th day, it was 2,43,000. So we again made little bit modification, that is Romiplostim 250 microgram once in 2 weeks. Now 60th day, the patient has got 2,30,000 and patient is very happy, and she doesn't want to discontinue Romiplostim because she doesn't want to have another thrombocytopenia. So now coming to case 2, it was a 9-year-old girl from Uzbekistan presented with gradual swelling in the right neck. Over a period of 1 year, they didn't have finance. Later on, they arranged some finance and came to India for treatment. We did the on examination, she had lymphadenopathy, anemia, and massive splenomegaly. Evaluated with lymph node biopsy, PET scan, and was diagnosed as classical Hodgkin's lymphoma stage 4. She was started on OIPA and Copdac. After the first cycle, after she was discharged, after giving the chemotherapy, at home she developed fever, bleeding, and altered syndrome. She was brought to the emergency. She was found to have severe neutropenia, thrombocytopenia, and anemia, and she was hypotensive also. Initially, we started with the empiric antibiotic. Subsequently, because the blood culture grew GNB, the specific antibiotics were changed. She received a lot of blood and single donor platelet, and also FFP because her liver function was, her PT-APTT was abnormal. She was on inotropes for 3 days, responded well, count came out with the GCSF, but she had persistent thrombocytopenia. After even 7 to 8 days, her platelets were less than 10,000, so we need to support. So 7th day, we decided to give Romiplostim, and we gave 125 microgram weekly. Her platelet gradually came up to 70,000 after first week, and after second week around 1,60,000. So we stopped Romi and she was given the next cycle. Now coming to case 3, this was a 81-year-old male, known case of coronary artery disease, hypertension, diabetic mellitus, and CA prostate. CA prostate was treated with hormonals and radiation in the past. He was suspected to have lesion in the liver and porta hepatis. With the surgeon, with the high PSA, surgeon wanted to do a biopsy. And now on evaluation, his HB was 9.4 gram%, total count was 7,170, and platelet was 45,000. There was no bleeding in spite of the patient being on ecosprin 75 milligram once a day. A systemic and general examination was done, which was unremarkable. So we thought probably it will be a MDS or even a ITP or even METS from the CA prostate. So we did a marrow. Marrow was mildly hypocellular marrow for the age with adequate megakaryocytes. There was no dysplasia, blast were 2%. Flow cytometry didn't identify any abnormal cells. Karyotype was done, which came later on, which was 46XY. Biopsy was hypocellular without any metastatic involvement. Virology was negative. So with the diagnosis of hypocellular marrow with thrombocytopenia with adequate megakaryocytes, we discussed the management with the family. We told them that we can do the procedure under platelet transfusion, or we try give a trial of Romiplostim, or we give IVIG. IVIG, they were not agreeing because the cost was very high. So we gave a trial of Romiplostim. Injection Romiplostim was given 250 microgram twice a week. And after 1 week, the platelet was 1,10,000, and ecosprin was stopped, and the procedure was planned, and pre-procedure platelet was 1,90,000. And the procedure went uneventful. I think his biopsy is still awaited. Maybe tomorrow it will come. So as we all know, Romiplostim is a TPO mimeter, is a peptide analog that increases platelet count by binding to and activating the TPO receptor. This is used for thrombocytopenia associated with ITP. We have used this drug in various approved as well as non-approved indications. In addition to ITP and chemo-induced thrombocytopenia, we have used in sepsis with thrombocytopenia in a very dire situations where there is bleeding and we are not able to give platelet support all the while. Thrombocytopenia in rheumatological diseases, post basically methotrexate, and they have responded well. Though MDS, it is not supposed to be used, it is supposed to convert them to ML. I remember using in 3 MDS patients, all were RCMDs with severe thrombocytopenia, where they were on kind of a palliative care and platelet transfusion. Always not possible, twice a week it's not possible. At least I remember one patient has responded to Eltrombopag, the other one has responded to Romiplostim, and one patient which was RCMD didn't respond to both, even if we tried Romiplostim, then Eltrombopag, there was no response. These are the 3 cases I wanted to present, this kind of experience we have got with Romiplostim. Thank you very much.
Thank you, Dr. Das. Wonderful cases. We move on to now second, Dr. Amita Mahajan, please.
I'll just...
Thank you, sir, and good evening to one and all. I'll just share my screen. It's not allowing me to share. Mr. Kalpesh has my slides if he would like to. Sir, are my slides visible?
Yes.
Okay. So I'd also like to present three cases, two in whom we have used Romiplostim. So all immune thrombocytopenias, but in settings that are sort of beyond straightforward, normal, newly diagnosed or persistent ITP. But in the third case, this is a case that I'm dealing with currently, and it'd be interesting to have inputs and whether we should or should not use Romiplostim in that setting. So the first case presented to a colleague at 4 years of age, many years ago. He was a resident of Bihar with isolated adenopathy, painless cervical adenopathy, and splenomegaly. There had been no systemic symptoms of note at all, and there had been no hematological findings. A lymph node biopsy had been done by my colleague, which was reported as just having reactive hyperplasia. The child had been, workup was done for other etiologies, but as the child was asymptomatic, the lymph node biopsy was reactive. It was decided to keep the child under observation. He was first referred to our team at 2 years later at around 6 years of age because he'd been coming for follow-up about 6 monthly. In the meantime, because he was from Bihar and he had seen somebody there, he'd actually received treatment for Kala Azar as well. At the time that I saw him first, he had only isolated splenomegaly. There was no significant adenopathy. There were no other hematological or clinical findings. So he was evaluated for hemolytic anemia, chronic infections, and other etiologies, but we could not find anything. At this point, peripheral blood flow cytometry was done for double negative T cells, but that was again normal. Bone marrow was done, which was essentially normal. So it was decided to keep the child under observation, and he kept visiting us at a median duration of 6 to 2 years for the subsequent many years. 10 years down the line, at 16 years of age, he presented with a short history of febrile illness, followed by a sudden increase and massive increase in splenic size, pancytopenia, generalized adenopathy, and actually renal dysfunction as well, which was found on evaluation. At this point, it was thought that perhaps he may have transformed to lymphoma or leukemia, but the bone marrow examination was again essentially normal. He had Combs positive hemolytic anemia. There was hypergammaglobulinemia, and vitamin B12 levels were elevated. And at this point, 10 years down the line, his flow cytometry did confirm double negative T cells, and we labeled him as autoimmune lymphoproliferative syndrome. He was treated with steroids and subsequently MMF. All signs and symptoms and even cytopenia, splenomegaly all responded, but symptomatic thrombocytopenia persisted. He responded to increased steroids dose intermittently, but the moment we were tapering the steroids, the thrombocytopenia recurred. He was given rituximab with no response. At this point, he was commenced on Romiplostim with excellent response, achieved normal thrombocytopenia, normal thrombocyte counts. The frequency was gradually decreased to 2 weekly for another 3 months and subsequently was discontinued. So this was ALPS with ITP that did respond very well to Romiplostim. The next case was the case of a 15-year-old girl who presented with short history of easy bruising and menorrhagia. On direct questioning, she did give history of repeated episodes of diarrhea requiring oral antibiotics and 1 episode of pneumonia for which she had been treated with IV antibiotics. On examination, she had bruising. Her spleen was just palpable, but there were no other clinical findings. CBC revealed marked thrombocytopenia with very low platelet counts. In view of this history and her age and newly diagnosed ITP at this age, immunoglobulin levels were sent, which confirmed hypogammaglobulinemia. And along with other workup, she was labeled as common variable immune deficiency with ITP. She was treated with IVIG with good response, but with very early recurrence. She was commenced on replacement doses of IVIG, but her thrombocytopenia persisted and the menorrhagia was problematic. She was given a short course of steroids with good response, but again with very short-lived duration. And we were reluctant to give her longer courses of steroids in view of the background of common variable immunodeficiency. I was also reluctant to offer immunosuppression in any other form, including rituximab or longer duration of steroids. And in this background, commenced her on Romiplostim. She had excellent response with platelets more than 100,000 after 3 doses. Her frequency was reduced to 2 weekly. And at present, her platelet count is around 75,000. And we are hoping that, and she's completely asymptomatic, to see whether we can get away without any further Romiplostim and have a platelet count above 50,000. The third case that is we are currently dealing with, a 17-year-old female with excessive bruising, menorrhagia, and gum bleeds. On eval, she was referred as perhaps ITP, but on evaluation, there was malar rash, and on blood workup, there was some degree of renal dysfunction as well. Because of the age and the clinical findings, workup was initiated for autoimmune disorder, and it did confirm SLE. She was commenced on steroids, HCQS, and she also received cyclophosphamide in view of the renal, she had a renal biopsy and in view of the renal dysfunction. And the other symptoms have all, she is achieved a normal status, but the thrombocytopenia is persisting. So in this case, we were contemplating whether to embark on TPO receptor agonist for her. We did screen her for antiphospholipid antibodies and lupus anticoagulant, but it was negative. So at the moment, we have, are still debating because of there is some evidence that in this setting, at least, the perceived prothrombotic risk with TPO receptor agonist may be enhanced. And I came across this recent report. It's just 16 patients from the French cohort which were in SLE, ITP in SLE, who were treated with TPO receptor agonists. And the summary of this report was that of 16 patients, they received either Romiplostim, Eltrombopac, or both. And they had received a median of 5.5 treatment strategies prior to this. They had an excellent response, but 3 out of the 16 had developed thrombotic events, 2 arterial thrombosis and 1 patient with venous thrombosis. So just to summarize these 3 perhaps off-the-mill cases, there are currently anecdotal reports in ALPS and CVID-associated ITP with both TPO receptor agonists. To me, this appears to be the logical choice for persistent on chronic ITP in patients with common variable immune deficiency if ITP persists despite replacement IVG. However, whatever little literature I could see seems to suggest that we should exert caution when we are dealing with the broader autoimmune disorders which may be associated with increased risk of thrombosis. Thank you.
Thank you, Dr. Amita. We move on to the third speaker, Dr. Shailendra Prasad Verma.
Good evening, everyone. And at the outset, I would like to thank MB Agarwal sir for this opportunity. Is my slide moving?
We can see it. Just make it full screen.
Yes, sir. Is it moving?
No, not yet. Put it in slideshow mode.
Okay. Now it is moving, sir?
Yeah.
Slide mode. Okay, I'll keep it in the same mode. So I'll be sharing the experience from Romiplostim in ITP and chemotherapy-induced thrombocytopenia at our center at King George Medical University, Lucknow. So we all know that currently TPO agonists are the main second-line options for managing patients with ITP, and they have superseded rituximab and splenectomy. Splenectomy is now far beyond in the options, and we have other options also like mycophenolate and azathioprine for management of ITP in second line and third line. So Romiplostim, we all know that it's a peptide which acts on the extracellular domain of TPO receptor, and it is given subcutaneously once in a week. While L-Trombopag and the other available Avatrombopag, they are oral molecules, they are small molecules, and they are given on the daily basis orally. So this is just a cartoon to show that Romiplostim acts on the extracellular domain of the TPO receptor, while L-Trombopag and Avatrombopag, they act on the transmembrane, domain of the receptor. And there are studies to show that Romiplostim has been quite effective in non-splenectomized as well as splenectomized patients of ITP, having an overall response rate of more than 80% and durable response rates around 60 to 60%. And if you see with the use of Romiplostim, the concurrent medications can be stopped or at least reduced in the dose, and the rescue medications needed during treatment with Romiplostim is also very less number of patients, 20% compared to 62% in control, which has been shown in the randomized studies. So with this background, we analyzed retrospectively, we analyzed all our ITP patients who are registered in our OPDs, and 20 patients have received Romiplostim between 2019 and 2020 over a period of 2 years, with a mean age of 27.7 years and male-female ratio of 9:11. Platelet count at the time of Romiplostim initiation was around 16,000, and duration of illness before initiating Romiplostim, median duration was around 19 months. These are the presentation of our patients at a baseline. So most of them presented with rash, gum bleeding. Females, most common presentation was vaginal bleeding, and some had epistaxis, and one patient had CNS bleed that was a chronic subdural hematoma at the time of presentation. If you see the line of treatment, all our patients got steroid as the first line treatment. In the second line, you can see that at our center, most of our patients are getting either azathioprine or mycophenolate. But 30% of patients got Romiplostim as the second line option, along with the few L-Trombopag and MMF. As a third line, again, 30% of our patients, 6 patients, they received Romiplostim as a third line, and 8 patients as the fourth line of treatment. As I have discussed, mean age was 27 years. Platelet count at diagnosis was 12,000, and at the time of initiation, it was almost 16,000. And at a median of 19 months, this treatment was started. We can see the response rate. So at 2 weeks, patients' mean platelet count was 83,000. At 4 weeks, it was around 71,000. At 8 weeks, it was more robust, around 1 lakh. And then at 12 weeks and at the later on times, there was a fall in platelet count. At 12 weeks, it was 87,000, and then at a median follow-up almost 14 months, the count was around 50,000. Mean platelet count was around 40,000. If you see the response rate, so complete response and response combined, 65% of patients had overall response rate in the form of CR plus R, and 35% of patients, 7 patients, they did not respond. They had no response to Romiplostim. So response rate was almost 65%. We also tried to analyze according to the age, sex, duration of thrombocytopenia, and line of treatment. So we didn't get any difference in response rate with Romiplostim based on whether age, sex, or duration. But comparing the line of treatment, we found that post third and post fourth line treatment, the CR and PRX combined were quite low compared to when it was used as a post second line, post first line, and post second line. So the responses were quite impressive in the initial post first line treatment, but later on with the passage of lines of treatment, the responses were slightly on the lower side. Rescue medications were needed in 8 patients in the form of MMF plus Dapsone, L-Trombopag, rituximab, or danazol plus Dapsone, and overall responses were seen in 5 patients. Only 1 patient could got CR with this rescue medication, and the rest all had only response, and there was no response in 3 patients who got the rescue medications while receiving Romiplostim. If you see the main causes of withdrawal or stoppage of Romiplostim, no response in 7 patients, which we have already seen. And then because of the financial constraints in the follow-up, 7 patients, they discontinued. Durable response was there in 4 patients, and in 2 patients, reason was clearly not known why they discontinued. Side effect profile was quite good. So only 2 patients had some local site reaction in the form of mild pain and edema, and 1 patient complained of flu-like symptoms, fever and generalized body ache. But there was otherwise there was no any other significant side effect while getting romiplostim. In chemotherapy-induced thrombocytopenia, we had a small experience of 9 patients. Basically, these are the referred patients from other departments like surgical oncology and gynecology, gynec oncology, mostly for solid malignancy, including lung, ovarian, and head and neck cancer, who are getting cytotoxic chemotherapies in the form of anthracycline, taxanes, and cyclophosphamide. And there were 4 new patients and 6 left progression cases who were referred to us for thrombocytopenia. Most common indication was the undue delay in initiating the next chemo cycle, and 7 out of 9 patients achieved a platelet count more than 1 lakh after average 2 doses of weekly romiplostim. And further 90% of these patients could receive further chemotherapy with romiplostim with weekly prophylaxis once in a week, 250 microgram. And 4 patients defaulted due to affordability issues. So we can see that even in chemotherapy-induced thrombocytopenia, this romiplostim acts very well. So to conclude, I can say with our experience that romiplostim is a promising agent in management of persistent and chronic ITP. 65% overall response rate, 35% non-responders. Post 3rd and 4th line responses were poor compared to post 1st and 2nd line treatment. 20% of patients could achieve long-term responses off treatment. There were no significant side effects. For chemotherapy-induced thrombocytopenia, most patients were able to maintain more than 1 lakh with 2 doses of romiplostim. And with romiplostim once a week, 90% of patients could complete chemo in a timely manner. With that, I would like to thank.
Thank you so much, Dr. Verma. Move on to the next speaker, that's Dr. Karuna Kumar. Karuna, are you ready? Okay, we have no response. We have no response.
Sir, just I'm joining, sir. I am sharing my screen right now.
Okay.
Sir, excuse me. Can I do presentation later, sir? After one more consultant finishes there.
Dr. Shilpa Gupta, can you take over?
Yes, sir. I'm unable to start my video. Can I just see whether the screen sharing is there? Is my screen visible, sir?
Yes.
I'm not able to switch on my video. Is that okay, sir?
Absolutely fine.
Thank you so much, sir, for allowing me to present in this webinar. Mine is I just have one interesting case which perplexed in terms of diagnosis also and treatment also. So this was a 42-year-old gentleman who presented to a different tertiary care center with history of fever since 3 weeks, and when he came to the hematologist, he was febrile. He also had bleeding PR and melena for 8 days. He had been transfused 2 packed cells and 21 RDPs in a peripheral hospital. Also, he had history of uneventful appendectomy done 4 years back. Occasional alcohol consumption, but no significant examination findings except for pallor. Patient had this following CBC reports. He had bicytopenia, which was persistent, and his immature platelet fraction was 63.2, which was high. So he had been started in the peripheral hospital itself with a dose with a pulse steroid, 1 gram dose of methylprednisolone, and was started on DEXA. When he was referred to the hematologist, the bone marrow was done after he had been given steroids. So it was done on 19th of November. The bone marrow showed hypercellular marrow with adequate megakaryocytes and normal trilineage hematopoiesis on biopsy. The doctor was suspecting possibility of MDS also. So they had sent the cytogenetic tests at 2 different labs, probably for academic interest. And one of the labs did not show any cytogenetic abnormality by FISH. Another showed 10% cells with deletion 5q and deletion 20q. Diagnosis was established as MDS with the unilineage dysplasia. Patient was started on danazol and romiplostim, and the DEXA was tapered off. Patient had not responded to methylprednisolone initially. Patient presented to us for a second opinion on 22nd January, and he had complaints of generalized weakness. There was no evidence of fever or any evidence of any bleeding anywhere. He had received 7 doses of romiplostim till then and was continuing on danazol. His CBC was showing improvement. Hemoglobin had picked up. Total count was slightly on the higher side. Platelets were also 58,000. Patient was apparently responding to the given treatment. So since he had just done a bone marrow and he had been through all sorts of treatments, so we did not proceed with any sort of change in the treatment, and same treatment was continued with addition of some hematinics. His CBC showed improvement. We continued with the weekly doses of romiplostim. So 2 more doses were given from our side, and hemoglobin increased to 9.6. Total count was normal. Platelets went up to 272,000. So overall, this picture was not fitting into myelodysplastic syndrome. Hence, since the platelet had become normal, romiplostim was stopped and he was continued on danazol. If it was because if clinically it was not fitting into myelodysplasia and there was no clear-cut diagnosis. So, but he kept a regular follow-up, but his platelets started dipping. And on 16th, it was 150,000, and by 9th of March, his platelet had dipped down to 23,000. Now, patient was largely asymptomatic, but since he had a 5q deletion in one of the reports, the thought process went in terms of why not start on lenalidomide and erythropoietin. So we started on that, and he did show some transient improvement with that. Hemoglobin was static, total count was normal, and platelet were more or less, it had increased slightly, 35,000. But a week later, patient presented with recurrence of severe biocytopenia. His weakness and fatigue had increased, and he had some mucosal bleeding. On CBC that day, it showed hemoglobin of 6.7 and platelets were only 2,000. There was a flag from the pathologist, red flag sign, that there may be an occasional blast. So the thought process, and we did an advanced CBC and repeated the peripheral smear, which showed the leukoerythroblastic picture, not exactly characteristic blast, but there were some nucleated RBCs on the peripheral smear. His retic count was high, his immature reticulocyte fraction was high, his immature platelet fraction was high. So we decided that we should do a repeat bone marrow to rule out leukemia in this scenario, or any other myeloproliferative or infiltrative disorders, myeloproliferative disease along with MDS, MPN kind of a scenario. So we did a repeat bone marrow, but again, it was coherent with the previous bone marrow, which did not show any evidence of malignancy. There was normal, it was normal to mildly hypercellular marrow with no dysplasia. Meanwhile, we had sent a workup thinking it to be because the platelets were too low. So ANA by immunofluorescence gave 1:1,000 positive. In view of anemia, we had done the direct indirect Coombs test and the workup for hemolysis, but that came negative. His fibrinogen was always less than 200. During this course of admission, he received a lot of transfusions, including fresh frozen plasma. He also had developed chest pain and breathing difficulty, which required ICU admission. Not a ventilatory support, but he had to be given oxygen support. The HRCT done at that time did not show any bleed, but it had shown some ground glassing. Probably it was related to an occasional concomitant viral infection. We did treat it with some antibiotics. He received methylprednisolone for 3 days, again in 1 gram dose, 2 doses of Romiplostim, one given on day 1 and 1 week later. During the ICU admission, we gave him 3 days of IVIG and also around 50 milligrams of L-Trombobag. So we had to almost give everything to this patient to get the platelets under control, because this was how his CBC was behaving. It just did not show improvement on day till almost 1, 2, 3, 4, 5, 6, 7, till a week. It did not show improvement. So we gave methylprednisolone here. We gave Romiplostim here. We started with IVIG on 5th here and gave a second dose of Romiplostim on 6th. Probably after that, his platelets started improving. And on day 9 or day 10, his platelets gradually improved to 76,000. And now the patient is on follow-up with us and he is doing fine with weekly doses of Romiplostim.
Thank you, Dr. Shilpa. We move to Dr. Gunjan.
Yes. Okay. Are my slides visible?
Yeah.
Okay. Good evening, everyone. So I'll be presenting a quick case, pediatric case of ITP, wherein I use.
Your screen doesn't see.
Yes. So there is this pediatric case of ITP wherein I have used Romiplostim. So this is a 13-year-old patient. At the time of diagnosis, the patient was 13 years in August 2017 when he was diagnosed with ITP, with the presenting symptoms of sustained mucocutaneous bleeds like epistaxis and gum bleeding. So it was found out that the platelet count was 5,000 with the hemoglobin of 11.2 and WBC 10,000. Direct Coombs test was negative. So he was treated with immunoglobulins and steroids, and he did not achieve any response. So again, in July 2018, the patient was planned for splenectomy after proper immunization, which after which he showed quite a good response, complete response, which sustained for almost 30 months. At the time of relapse, again, he presented with gum bleeding, severe asthenia, and here this time the platelet count was 12,000 with hemoglobin of 11. This time he refused to be treated with steroids. So again, IVIG treatment was planned. The first dose was given for 2 days, 1 gram per kilograms, which showed transient response. Platelet count jumped up to 296,000 and again went down to 12,000 on day 10. Followed by second cycle, which was given as a single dose of 0.8 grams per kilograms. 21 days thereafter, achieving similar response, wherein the platelet jumped from 9,000 to 134 and back to 3,000 on the day 10. Further, as a maintenance treatment, 4 cycles of 15-day cycles, wherein 4 days of dexamethasone, 40 milligrams daily was started without observing any further response. Patient was doing well clinically. As this patient wanted, now he was a mature adult and he wanted to continue an active life. So he was then started on Romiplostim. This time he was 17-year-old and his platelet count when we started was 2,000 with a dose of 3 micrograms per kilo. Here the patient responded quite well up to with the platelet count going up to 3 lakhs after 2 weeks. So he was again maintained on Romiplostim, wherein the platelet count ranged between 1 lakh to 1,80,000 with a dose of 2 micrograms per kilograms. After his 1 year of treatment with 2 megs per kilo, again Romi was interrupted for 2 weeks and there was a sudden decline of platelet in the 3rd week without treatment to up to 47,000. So after this, again, Romiplostim was he was retreated with Romi, and the number of platelets steadily increased. Currently, he's still ongoing with the Romiplostim every 3 weekly for almost 12 months now, and he's doing quite well. So I would want to highlight on a study wherein children with chronic ITP of more than 6 months were given weekly subcutaneous Romi. In this study, the median average weekly dose was almost 4.8 mg per kilo, and it showed median platelet counts remained almost about more than 50,000 from starting at the week 2, and 65 children received this Romi for over median years of 2.6 years. And the baseline age was 11 years in this study, and the platelet count was 28,000. No patient discontinued treatment for an adverse event, and nearly almost 94% had at least more than one platelet response, good response, wherein there was no rescue medication given in the prior 4 weeks, and it was maintained over 50,000. 72% responded at more than 75% of the visits, and 58% responded at more than 90% visits. So here the treatment-free response was seen in 15 out of 65 patients while on off Romiplostim, wherein the platelet was more than 50,000 for more than 24 weeks without any treatment. So in this 7-year open label extension, 3/4 of the patient responded more than 75% of the time. Romi was well tolerated without any adverse effects. And importantly, 23% children maintained treatment-free platelet responses while withholding Romi medications for more than 6 months. So this is my last slide, wherein the challenges which we face in India is the difficulty in compliance of long-term treatment and frequent follow-ups, risks of infection which we face after splenectomy, and majority of patients, as we all know, cannot afford TPO-RAs at the current cost which we have in India. And Romi was, now we have been using it right, left and center, but it was not available till recent past. Thank you.
Thank you, Dr. Gunjan. We will take at least one more speaker, Dr. Purva. We have the international guest speaker speaking to us at 8:30. So in case we don't finish it, we will come back to Dr. Aditi and Dr. Karuna Kumar a bit later on. So Dr. Purva.
Yeah, thank you, sir. Good evening, all. So, I'll be talking about our experience with Romiplostim in ITP. So, in pediatric ITPs, especially, the choice of treatment depends on a number of factors. We look at the age, the gender of the child, and also a lot of psychosocial considerations are taken, especially in an adolescent girl, where even a cutaneous manifestation, like cutaneous bleeds, also are taken into considerations. And finally, the ease of administration and expected adherence. So, with all of that, as I say, as in pediatric ITPs, the platelet count, like in all others, doesn't matter. We had a lot of options before, like, rituximab, azathioprines, but they were associated with their own effects. So, with the introduction of TPO agonist, it has really helped in the treatment. So, I'll be sharing our experience with Romiplostim. We started using it around the time of in 2019 in August. So this was the protocol where we used. We started at 1 micrograms and we slowly increased depending on the response. So out of the total 90 patients who were registered with us, we used Romiplostim in total of 8 patients. One was a kid with persistent ITP and the others were chronic ITP. So the average age of presentation of these children was 7 years when they first presented at ITP. And when Romiplostim was started, it was started when they were around 11 years of age. So the mean years since the diagnosis till Romiplostim use was around 4 years. There was a female preponderance. So all these patients, when they presented to us as ITP, had bleeding manifestations. Most of them were mucocutaneous. None of them had visceral or intracranial bleeds. 7 of them responded to steroids. And 1 patient had to be given IVIG in view of persistent bleeding. So these children, whenever they were given any first-line agent, there was a response. But whenever it was stopped, we had on follow-up that they had number of episodes of bleeding. Few of the girls who were younger later on developed menorrhagia. And the average platelet count which they maintained was around 10,000. 85,000, or whenever any rescue medication was given, it was increased. So any chronic ITP or a persistent ITP, we completely work them up before labeling it as an idiopathic. So all these patients had no underlying immunodeficiency or underlying disorders. So as a second line, we had used Dapsone that time in all our patients. 2 we discontinued. And so Dapsone, though there was no platelet rise, 3 patients had no bleeding. But due to compliance, they were changed to Romiplostim. With mycophenolate mofetil, we had no response. And L-Trombopag was showing good response, but due to financial constraints, had to be stopped. So our experience with Romiplostim is that 4 patients, so they showed a good response, but they showed a response at high doses. It could be maintained, but the moment the dose was reduced, it fell less than 10,000, and few of them had bleeding manifestations. So 3 of our patients had good response. One patient had a response at 5 micrograms, but as this patient was lost to follow-up during the COVID pandemic. The other had a transient response between 3 to 6, and then the response was lost. The remaining 4 patients, they had no response. 2 patients had bleeding episodes during the trial of Romiplostim, so had to be stopped and required rescue medications. To summarize our experience, none of our patients had any side effects related to Romiplostim. Complete response was seen with 3 patients, but this response was seen at higher dose and at some point had to be stopped. Partial response was seen in 1 and no response was seen in 4 patients. So the advantages that we saw was because it was an injection, we could ensure the compliance. So in our setting where it is a charitable hospital, what we did is to make it cost effective was we combined patients together so that the cost could be, so that there could be like cost. We could see to it that, the patients could not miss the dose. And as far as the side effect profile, none of them had any side effect. The disadvantages was that hospital visits were necessary because it was a weekly injection. And the limitations of what we are presenting, because it was a small cohort, we cannot definitely say whether it was useful or not. And few of the times we faced logistic issues. The other place where we used Romiplostim with a wonderful outcome was in an inherited marrow failure, where there was a wonderful response to Romiplostim at a very low dose. But again, this child was lost to follow-up during the COVID pandemic. So I would like to say that Romiplostim is a promising drug in our children. It improves the quality of life. Especially in adolescent girls, this was what they had preferred. We got that there was a good compliance and it was well tolerated in them. But to say that, we need to study it better in our cohort and we need to see their long-term follow-up. Thank you for a patient listening.
Thank you, Dr. Purva. We move to Dr. Aditi.
Thank you, sir. Good evening, everyone. So I would like to present a short case series of use of Romiplostim in ITP. This data is from KEM hospital, which usually treats patients of lower socioeconomic strata. So we have used it mainly in relapsed or refractory setup. Case 1 is a 47-year-old male presented in 2018 with history of fatigability and per-rectal bleed. Presentation platelet count was 12,000. Initially started on steroids with partial response, but there was loss of response at 4 weeks. When MMF was added, MMF showed good response, platelet rose to more than 1 lakh. However, patient developed recurrent oral ulcers, which hence it was subsequently tapered and stopped at 9 months. Following which patient was maintaining platelet count of 50 to 70,000 for a year. Relapsed after a year with a platelet count of 14,000, restarted on steroids. At this time, there was no response to steroid, and when we added Romiplostim. It was started at a dose of 250 microgram, because we didn't want to, which was about 3 microgram per kg. Just with 2 doses, platelet count rose to more than 1 lakh. Following this, patient was continued on 250 microgram weekly dose. We could get the drug via some support, and he maintained platelet count from 75,000 to 150,000 in the next 1 year. At a year, we tried to stop romiplostim at the platelet count of 90,000. However, after 6 weeks, platelet count again dropped to 12,000, and we restarted romiplostim. Since then, patient is on weekly romiplostim, and the recent platelet count is 253,000. So here is a case of steroid resistant with complete response to romiplostim. Case 2 is a 14-year-old female at presentation platelet count of 8,000. She was started on steroids. There was no response to steroid, hence MMF and dapsone was added in the first month itself. She did not show a response to both, and she was counseled for rituximab or TPO agonist, but in the beginning she was not willing for the same. At 6 months, platelet count was still less than 10,000, and rituximab was given 4 doses. There was no response to rituximab at after starting at about 2 months, and romiplostim was added. She was also evaluated for secondary causes like autoimmune disorder, immunodeficiency workup, all of which was negative. After 8 doses of romiplostim, there was still no response, but one significant finding was that she always complained of menorrhagia and intermittent epistaxis. And there was a marked symptomatic improvement since romiplostim was started. Eventually, she had to go for splenectomy, which was recently done in first week of June. Post splenectomy on day 1, her platelet count rose to 80,000. However, after a week again dropped to less than 10,000. So this patient, we are stuck right now, planning to restart on romiplostim and counsel her for L-Trombopac. Case 3 is a 35-year-old female railways employee presented in Feb 2021 with a platelet count of 10,000. She was also started on steroids with no response when MMF was added. Platelet count was low, less than 20,000 at 5 weeks, and L-Trombopac was also added. She was on MMF and L-Trombopac, maintaining platelet count of 30,000 with no bleeding manifestation. However, she complained of fatigability always. And at this point in time, we changed L-Trombopac to romiplostim. After starting romiplostim, after first dose, platelet count rose to 74,000. And after 8 doses, it's maintained around 68,000. MMF was later on gradually tapered and stopped. She is on single agent romiplostim since a year and maintaining platelet count of about 60 to 80,000. And case 4 is a 13-year-old male, same at presentation platelet count of less than 20,000, received IVIG elsewhere, presented to us 1 month after IVIG with a platelet count of less than 10,000. We started him on steroids, no response, added MMF and dapsone, which is our usual second line choice. There was partial response to both. However, after 6 months, there was loss of response, at which romiplostim was added. He had partial response to romiplostim. However, he stopped all medication and there was loss to follow-up for 2 years. Presented again 6 months back with a platelet count of less than 20,000. At that point, romiplostim was restarted. And now he's maintaining platelet count of about 30 to 50,000 without any symptoms. So we have this presented 4 cases of chronic ITP where romiplostim has been used at a dose ranging from 3 microgram per kg to 7 microgram per kg. 1 patient had complete response, 2 had partial response, and 1 had no response. However, the patient who had no response did have improvement in her bleeding manifestation, and none of the patients experienced any adverse events. So with our experience, 3 out of 4 patients had sustained response with single agent romiplostim, and hence I feel it is an effective and a well-tolerated treatment option for patients with ITP. Thank you.
Thank you so much, Dr. Aditi. We have our international guest speaker with us. It's my privilege to introduce her, and I'll be requesting her to start her lecture. So we have Dr. Cindy Nunett with us from New York. All of you know her. She has been our faculty at multiple occasions, both in person as well as through the web. She's associate professor I'm sorry, Pediatric Section Head, Pediatric Hematology, Columbia University Medical Center, New York. Sorry. She did her fellowship from University of Texas Southwestern Medical Center. She's an expert in benign hematological disorders. Her areas of research and specialization include immune thrombocytopenia, hemostasis, thrombosis, and sickle cell disease. She's involved with the Intercontinental Cooperative ITP Study Group, which is an international study group advancing knowledge regarding the natural history of ITP in children and adults. She is author of the American Society of Hematology 2019 Guidelines for ITP. She was past chair of the Pediatric ITP Consortium of North America, which is a group of 40 pediatric centers conducting studies on the biology of ITP, as well as the conduct of patient-oriented and interventional trials. She now serves as the co-chair for the interventional subcommittee. I request her to give a talk on Romiplostim-based treatment of immune thrombocytopenic purpura and chemotherapy-induced thrombocytopenia. Over to Dr. Cindy.
Thank you. Thank you. Good evening, everyone. I'm still drinking coffee, so where I am, but good evening to you all, and thank you. Always a pleasure. Let me share my screen so that you all can hopefully see my slides. Can you see slides now?
Yeah.
Great, great. I may turn my camera off from time to time if my internet gets a little blitzy, but so it's really a pleasure to talk about Romiplostim for ITP and chemotherapy-induced thrombocytopenia. And I wanted to start just by providing a brief overview of the thrombopoietin receptor agonists, and then a little bit of focus on Romiplostim. We'll review data for use in ITP and some emerging data for chemotherapy-induced. And then, as always, what I love about giving talks to this group is to engage in a lively discussion of our real-world experiences. So when we think about the TPO-RAs, it's based around megakaryocyte development. And we know that this, we have different markers as megakaryocytes mature. And one of the cell markers that's present on our mature megakaryocytes is the thrombopoietin receptor. And so tapping into this, people purified and cloned the TPO, TPO in 1994. It's mostly produced in the liver. It contains two domains, and then its main receptor is the c-MPL receptor, which is located on chromosome 1p34 and expressed sort of throughout megakaryocyte development. How TPO is regulated, there's kind of two models that exist. It does vary inversely with the platelet count, and a lot of people have looked at how we can use TPO levels to kind of guide us in our diagnosis, perhaps. We get maximal levels within 24 hours of being thrombocytopenic. So it's a rather responsive bone marrow stimulant. So here's a constitutive model. This is where it's actually getting cleared along with our platelets. So it binds to platelets and gets cleared, and that's sort of what maintains our turnover. The other is that it's a little bit more need-based. So low platelet counts induce gene expression. You have increased TPO in the bone marrow of thrombocytopenic mice. And this is why people think maybe it is a little like EPO, where there's a sense that there's a drive and a need for more TPO production, not just that it's getting cleared off the platelets. And as platelets break down faster, you get more release of TPO. And this was recently also confirmed in human tissue. So again, two models. One is increased turnover leads to greater release of the bound TPO back into circulation. The other is that there's actually a signal that gets sensed that causes increased production. Here's our TPO pathway. Once it interacts, here's our receptor, becomes active. We have a JAK-STAT pathway over here, and then also a RAS pathway over here. And the molecules are interacting, our different TPOs interact with different areas within this receptor. So what about the TPO-RAs in ITP? And I think everybody kind of knows the story. We kind of started with recombinant TPOs. We started with native TPO that led to severe suppression antibody formation towards thrombopoietin in healthy controls. And so now we have these recombinant forms. Here's the main ones that exist. There's Romiplostim, L-thrombopag, avathrombopag, and lusothrombopag. And they are a little bit different again in where they bind, but they all essentially act in the same way, which is to try to activate that downstream pathway. They vary a little bit as well in how they're given, with Romiplostim being sub-Q and then the others being oral. And what we need to monitor for. The other big one is that L-thrombopag has this hepatotoxicity that is not seen with the other agents. So the focus of this talk is on Romiplostim. It was formerly known as AMG 531 when it was in the development pipeline. It is a TPO peptide mimetic. It has an FC carrier domain that prolongs its half-life, which is why it's allowed to be given just weekly. And then the peptide portion is what has its active binding site. And this has no sequence homology with native TPO. So native TPO can still simultaneously be binding while we're trying to increase by using Romiplostim. And as we've talked about, it's a sub-Q weekly injection, which I find actually, practically speaking, a lot of my patients really prefer. It's amazing. I thought everybody would kind of have injection phobia, but I think actually what they hate more is taking a pill every day. The downside, of course, to drugs and drugs in development, at least based on US cost, is just how much they cost per vial. And I will say again, because of this, when I'm working with dosing a patient, I try to round to the nearest vial, so long as I know that's still going to give me a platelet count that matches our goals. So in terms of side effects, the time to the platelet count is about 10 to 21 days. The most common side effect is a headache. If you can believe that, it's not really anything related to all the things that we worry about, which are thrombosis, bone marrow reticulin, or other big problems. The development of bone marrow reticulin with the TPOs, I think, really started out as a major concern, but we now have large data sets from adults that have undergone surveillance bone marrows to sort of say we really don't have to have that concern. There was really no increased formation in reticulin above baseline, and if there was, it really wasn't to a signal that caused concern, and no real concern that we're driving an inappropriate marrow response. There was also some concern about thrombosis. This is really, I think, still a little bit hard to wrap our heads around, in the sense that we know patients with ITP also seem to have some inherent risk for thrombosis. The thrombosis risk isn't necessarily just seen in patients that have extreme thrombocytosis from being on the TPOs. And when you look, it might just be that it's really not that elevated, but I do think it is a signal. I talk to patients about it, I counsel them about it. I have to worry about it a little bit less in the pediatric population than in the adult population, which is where most of these events have been reported. It's important to note that severe bleeding and thrombocytopenia can occur with abrupt discontinuation, and there's working groups that are trying to figure out, how do we stop, how do we taper off? Should patients be bridged with a course of corticosteroids perhaps, or just have some emergency steroid use at home? Patients can have quite severe dips with immediate discontinuation that can even go lower than they were at baseline and have bleeding symptoms that they previously didn't have. There's been one patient that's developed anti-Romiplostim antibodies and stopped responding to drug. There has not been any reports of development of those antibodies and also reacting to native TPO. So in that sense, it seems to be relatively safe. As we start to talk about chemotherapy-induced thrombocytopenia, I think this is an important point. You know, there was a concern about increased risk of hematologic malignancies. Again, are we sort of driving the bone marrow to do something that it doesn't want to do? I think this concern primarily came about when the bone marrow reticulin story started to trickle out in ITP patients, and then even more so when there was a thought about using these drugs in patients with aplastic anemia or myelodysplasia that may already have an increased risk for leukemia. Most recently, the data, at least in the MDS population, is that there doesn't seem to be an increased concern for clonal evolution between patients who receive this drug and placebo patients. So I feel like that's probably a good reference population, because that truly is the population where if there was concern for clonal evolution, it would be present. We're not seeing it there. So I think that can give us a little bit of a sense of relief that we don't necessarily have to worry about it in other settings as well. How do we dose it? It's dosed based on sort of weekly platelet counts, although I know practically speaking, many of us, once you find the kind of magic dose, going monthly is even better. And that's what they did in the research trial. This is from the research trial where they started out weekly, and then once you achieved a stable platelet count, could switch over to monthly. It's based on, because obviously in clinical drug trials, we're trying to find safety data. I think this is a little bit conservative dose adjusting in that it's based on trying to maintain above 50, not adjusting until you're over 200 or 400. I can tell you again, one, for ease of administration using a single vial. I really sit down with families and kind of map out what their goals are, what platelet count achieves those goals. And if I have a patient that's doing really well at a platelet count of 30 on the 125 vial, I don't necessarily increase them and cause them to go into another vial just to hit that 50,000. We kind of sit tight. So I think there is a little bit of wiggle room here. The other is this starting dose. The starting dose of 1 mg per kg, again, is based on the clinical trials where we were trying to sort of find the ideal dose without going over. And I can tell you again, kind of practically and anecdotally, that many of us I oftentimes will start on 2 or 3 mics, depending on the clinical situation, and really ramp up, not by 1 mic per kilo, but closer to 2 mics per kilo. We know that in clinical trials, the average is around 4. Many patients require 10. It's very unlikely that somebody in the early phases of dose adjustments is going to really go above 400. I see that in the setting when patients are already starting to maybe have their own spontaneous remission on top of Romiplostim, or they're getting some other therapy, or there's something else that kind of causes a boost. I've yet to see it starting on a higher dose in a new patient that's at 2,000. It's very unusual that I've seen them jump all the way up to 200 or 400. So I do start a little bit higher and move up a little bit more quickly. This is from chronic ITP adult data. This was the early data that was looking to get the indication. There was maybe a slightly better response in splenectomized patients, in non-splenectomized patients compared to splenectomized. In theory, that may just represent a more kind of refractory group of patients, not necessarily something about drug mechanism in those patients. But in either case, Romiplostim performed much better than placebo with both durable response and overall response. And here's long-term data, and you can see this really was maintained. And here's our median dose. So again, 4 milligrams seemed to be good. It does look like over time there was maybe an slight increase in that median dose, but targeting around 4 to 5 as a starting dose probably makes sense. And then here's our mean platelet counts across the entire group, and you can see that it rarely dropped below 50,000. So effective therapies even over a long duration of time. If we look at some pediatric data, there was a randomized pediatric trial, very small. Again, it was in chronic pediatric patients at that time defined as 6 months. There was no serious treatment-related adverse events. Again, headache was most common. Bone marrow reticulin was not monitored, but there were no safety signals regarding that, no neutralizing antibodies, and a very similar median weekly dose to the adult data, again, around 4 to 5. This just gives us some indication that similar to adults, if we looked at very short definitions of response, just 2 consecutive platelet counts, 88 versus 0. Bleeding rates were reduced. The need for rescue therapy was reduced. And in looking at patient-related outcomes, the use of this also reduced parental burden. And here's a similar mapping just showing median dose, as well as the fact that the platelet count for the majority of patients, the majority of the time was over 50,000. This was our kind of we did this as a labor of love project. We went back through all of our patients who had received a TPORA retrospectively among our consortium. And we had individuals, two investigators look at a mapping of the platelets over time in patients. And what we found was that we described a subjective response as either stable, so a nice straight graph, intermittent, meaning up and down, a response that started and then the patient lost that response, or just no response at all. And then we also had this category of other, which kind of represents patients that weren't on drug long enough for us to assess, comments about non-adherence patterns, things like that. But what you can see is a third of patients had that nice line, a nice good platelet count, but there were several that were sort of up and down or had a response and lost it. We had about 33% in the other though. So again, patients that weren't on long enough, patients we couldn't assess. So for some reason, this group of patients, this wasn't their ideal drug. So as much as we know from clinical trial data, the majority of patients do well, this really showed us that for a lot of patients, it can be an up and down journey and or it's not the right drug for them. So what about our guidelines? How do we use this? Our data says Romiplostim is a great drug for ITP, right? The clinical trials said this is a really good therapy. There's no reason not to be using this therapy. When we look at it in adults, it became a little bit complex. We were trying to compare three very different therapies: splenectomy, rituximab, and the thrombopoietin receptor agonist. And what we found was it's very, very hard to do. There's no head-to-head trials. There's nothing that really tells us how to do that. And what we ended up with was this very kind of flowchart thought process of what we should consider in which therapy we offer to which patients. And the first really branch point was how long have they had ITP? So have they had ITP for greater than 12 months or less? If it was less, we really didn't think splenectomy should go into the conversation. Over 12 months, splenectomy can be part of the conversation. And then the branch points were really patient values and preferences, whether or not they value drug-free remission, whether or not being on a daily medication or weekly medication fits with their lifestyle, what were their goals, which medication might serve those goals better. Pediatrics, we've got to be a little bit more clear because I think in peds we're so side effect averse that we really like the fact that these TPO agents seem to have the cleanest side effect profile. So really they were thought to be preferable to rituximab and certainly to splenectomy in the pediatric population. I will say though that in adolescents, particularly adolescent females, rituximab may have a role. It seems that the adolescent AYA females are the ones in which rituximab may have a lot of benefit or more benefit. But we really in peds felt the TPOs offered nice bridge therapy. A lot of children will still continue to spontaneously remit. It allows them to do that with the least exposure to side effects. So what about chemotherapy-induced thrombocytopenia? This is, I think an exciting area. I think with ITP, we've got a lot of good substantial data. I think, as I said, the guidelines really are supportive of using the TPOs. In the US, all three of the ones available in the US have FDA approval. So I think we're in a good place in terms of TPOs and ITP. I think certainly the fun part when it comes to TPORAs and ITP is how to have that engaged discussion with a family and really make sure that you're meeting their goals. With chemotherapy induced, this is an interesting new area. And I'll focus on chemotherapy induced, but the other area that we've had a little bit of interest in with my group is with bone marrow transplant as well. But approximately 1/4 of patients will experience some reduction or dose delay because of counts. And when we're thinking about trying to do interval compression, when we're trying to get the most timely chemotherapy in, this really may lead to downstream negative outcomes. Treatment-related thrombocytopenia can occur at rates close to 20%, With more intensive regimens, this goes up to 30%. And as I mentioned, delays in relative dose intensification can impact outcomes. There was one other therapy designed for this space. It was recombinant IL-11 and it was approved, but because of the high risk of side effects, it really got abandoned in clinical practice. It was never clinically applied. The side effect profile was so high that the risk really didn't outweigh any clinical benefit. But now the use of Romiplostim and some of the other TPOs has kind of expanded into this space. I think the reason that Romiplostim has kind of been the one that's had the greatest focus is because it allows for that once weekly injection. I think it's easier to sort of titrate up very quickly. I do think that the weekly dosing kind of fits with how we think about GCSF use, we think about chemotherapy cycles, and that makes it a very appealing drug to kind of navigate into treatment protocols for chemotherapy. And I think that's why it's gained the most attention as opposed to adding another daily oral medicine to a patient that may already be struggling to keep up with a lot of other oral medications on their plate. So I loved this. This was a meta-analysis done very recently in 2022. And what they found was they screened 1,500 titles roughly. They were able to pull close to 140 that seemed to fit to get full assessment. There were 39 publications that were identified, only 9 of which were specific to Romiplostim, and then there were a couple others for L-thrombopag. There were even some really old studies with the human TPO. So we're really looking at a very narrow field that I think has lots of potential for new development still. So this was the meta-analysis results. And as you can just see by a quick scan of the p-values over here, they really weren't able to show a clinical benefit across all the studies. So they weren't really able to show when combining the studies that chemotherapy dose delays or reductions in chemotherapy were minimized with the use of Romiplostim. They weren't able to show reduction in WHO grade 3/4 thrombocytopenia occurring. This I thought was interesting. They weren't really able to show a reduction in platelet transfusions. And again, I think with certain cancers, or even as, again, we're talking about bone marrow transplant, avoiding that platelet transfusion exposure is really critical and would be another good goal and outcome of being able to use the TPOs. And they weren't able to show benefit there either. And then again, with the greater than grade 2 bleeding, and then looking at a negative outcome of thrombosis, it did not appear though that there was an increase in thrombosis. So kind of looking at the other side of an increased risk. So when they looked at really clinical outcomes, they weren't able to show much difference, but they did state, you know, their takeaway from this was really that there's room to keep going. This isn't a closed door. There were enough studies with positive effects that this merited just better design of studies, larger studies, and more clinical information. So they didn't shut the door, despite not finding an effect. And the reason for this is that they felt there may be a lot of publication bias. There's no ability to compare between the TPOs. So again, talking about is Romiplostim really the right drug? Is L-thrombopag better? Is there something we're not thinking about there? In my mind, just conceptually, as I said, I think Romiplostim seems to fit. There's no studies on cost effectiveness. So again, when you're looking at an outcome like platelet transfusions, that would be a cost offset, right? If you can show a reduction in transfusions, if you can show some cost saving clinical benefit, time spent in hospital, something along those lines, then that might also support routine use. But to this last point, and where I want to spend some time, is that there's highly variable dosing schedules. So we don't really know the ideal dosing. We don't really know how to apply these yet. So this is one dosing study. Unfortunately, it was just an abstract. I've not been able to find the full paper yet. This was using AMG 531 for non-Hodgkin's lymphoma. They had a small number of patients at each dosing level, so 1, 3, or the full 10 mics all at once. And they did it in 2 different fashions. They had an arm A and an arm B. And what they were really looking at is, do you need it pre and post-cycle, or is it okay to just dose after the cycle? So either patients got it on day -5 and 5 or days 5 and 7. And what they really found was that on all clinical outcomes, the pre and post dosing was the superior way to do it. That really was what gave you the best benefit over placebo. There was still benefit using the day 5 and 7 approach, but not nearly as significant as when you did it pre and post. What I couldn't tease out in the data was exactly what dose was the best. Was it, the 1, the 3, or did most patients require the full 10? But you can just see here with regards to outcomes, clearly our superiority in this group with regards to platelet nadir, days with platelet count less than 100, and then number of transfusions. Here's a second dosing. This is Dr. Al-Shamkari out of Boston, and he's done a lot of work in this field. I think he's still continuing to kind of plug along and find the right signal. This was in both solid tumors and hematologic malignancies. And again, what he was looking at is, does it need to be weekly, or is intracycle dosing sufficient? And very similarly, what was seen here is that it really does need to be weekly. And that's probably just because what they were, alluding to is the fact that, and this comes out of also some kinetics papers, is that by the time if you only give it pre, and then by the time you start to see that decline, it kind of is too late to get the bump. And it's probably fine to keep going because nobody ever really gets high enough that you hit the danger signal. I reached out to a friend of mine in pediatrics because we've been using this a lot more in our pediatric oncology patients. We've actually had some patients that have become platelet refractory for various reasons, or we've had a lot of difficulty just even getting them home because of their frequent needs. We are expanding into bone marrow transplant. So I reached out to a friend of mine who did her master's thesis paper on this and did a project in the pediatric space with solid tumors in pediatrics, where that interval dose intensification is so important. And this is her anecdotal. What they found was that the majority of patients really needed to go up to 10 mics, so they just start now on 10 mics. They found that it really, nobody overshot with this, and it really provided the most kind of consistent. So they start with 10 mics on day 1 of the cycle, and they continue weekly. Similarly to what was found in the Boston adult study, they found that by just continuing weekly, right as the counts were about to recover, patients were about to get their next dose of chemo, they really found no harm in just continuing to push through. They would hold if there was a platelet count over 400,000, they would hold for a week and then resume at a lower dose, but that really was rarely encountered in her experience. And so now for the patients that I work with, this is sort of what we've started to apply. I'm still a little, because I don't have my own experience, I don't quite start as high as 10 mics, but I'll learn from my own experience and maybe get a little bit more comfortable with that. So in conclusion, and just to have time for kind of, again, my favorite part, which is our more lively discussion, because I know you all always come with so many great ideas and thoughts of your own. But TPOs have been shown to increase the platelet count in different settings. There is no doubt that they are effective therapies, and they're well-tolerated therapies. I think when we, particularly for ITP, start to compare them to the side effects of other treatments, they're rather well-tolerated. But I think additional information is needed on patient-related outcomes, cost, and long-term benefit. One could argue that's still needed in ITP. We really haven't focused on the patient experience with TPOs and the cost of TPOs. I do think we have good data on long-term benefit. And then when it comes to the chemotherapy space, I feel like this is a wide open space where it's kind of exciting to think about. I would love to see that these can make a difference in patients undergoing chemotherapy the same way GCSF has. I don't know if we'll get there, but maybe, and it certainly would be exciting if we did. So that's a quick overview. I know that was a lot of information, but I know so many of you are already familiar with the ITP data that's out there. The chemotherapy space is really kind of cool to me. And I actually learned a lot kind of updating myself on what's out there for this talk. So it was fun and a good topic. I'll stop sharing now so I can see anybody who's on. Much nicer view.
Thank you, Dr. Cindy. That was fantastic. Especially the second half was quite new to us. We have some of our discussants, Indian colleagues. Joining us is now Dr. Ashish Dikshit and Dr. Dinesh Bhurani. I'll just briefly introduce them. Dr. Ashish Dikshit is from Manipal Hospital, Bangalore, and Dr. Dinesh Bhurani is from BLK Max Super Specialty Hospital, New Delhi. And we also have our colleagues who presented cases this evening. We have Dr. Satyaranjan Das, Dr. Amita Mahajan, Dr. Shailendra Prasad Verma, Dr. Shilpa Gupta, Dr. Gunjan Lone, Dr. Purva, and Dr. Aditi. So those of you can open your videos, that will be fantastic. We can see each other and have discussion. So those who want to start asking questions, please raise your hand and go ahead. Maybe in the till you do that, I can ask one question to Dr. Cindy. In patients of ITP, some of the patients have potential cure following use of Romiplostim. What is that exact percentage, and how long does it take for them to get cured, and what is the mechanism?
Yeah, it's a really fascinating new kind of development within the TPOs. And what you're speaking to is there's sort of an induction of sort of immune tolerance, right? If you continuously expose the body to, or at least this is the proposed mechanism, right, to high levels of the platelet antigen, does the body eventually just accept that it's there and it's normal? Very similar to what we do with hemophilia patients that have inhibitors, and we just give them very, very high amounts of factor until the body just exhausts the immune system. I would say, and we have to be very careful when we talk about this, because the papers may use the term remission. What we're really seeing is kind of a drug-free response, right? So it's sometimes they define it as over 30, it's kind of patients able to maintain a platelet count greater than 50,000 without drugs. So it's not necessarily a remission, but it's very refractory patients that now all of a sudden used to be 2,000 without drug and now can live at 50 or 60 and be drug-free. And that's probably, of the responders in the adult world, it's probably about maybe 20, but it takes years. Some of these are patients that have been on the drug for 3 years, 4 years. And so the discussion was that their natural evolution anyway? We don't have a comparator arm yet, right, for what would have happened to them anyway. People are doing a lot of work to show the biologic plausibility of that. They have shown that there's Treg changes and other changes that occur long-term after being on the TPO-RAs. It's going to be interesting. I know there's open studies trying to look at this more, because but I think the problem is not really knowing what was going to happen anyway. But these were really refractory patients, but sometimes it takes years. I mean, there's reports of them 4 or 5 years. It's not a quick response, right? It's not just after 6 months of use that we're seeing this. It's really after that chronic exposure to antigen at higher levels than they're used to, that we get that immune exhaustion.
Thank you. That was very good. Excellent. Dr. Aditi, your question.
Thank you, ma'am. I have a question. In case of pregnancy with ITP during 3rd trimester, non-responding to steroid who cannot afford repeated IVIG, would you recommend use of TPO agonist in this setting?
Oh, so Terry Gernsheimer is the best person to ask that question to. This is a field of hers. I think we are starting to learn that they are safe. The evidence that is coming out is showing they're safe. I still think that the go-to drug of choice is azathioprine, and it's less expensive as well, and it definitely has been shown to be safe in pregnancy. But I do think most of the data coming out on the TPOs is that they are safe in pregnancy. They are still classified as not to be used in pregnancy in the US. So we still would kind of consider either family planning around rituximab or the use of azathioprine.
And ma'am, if someone is on TPO agonist and conceives, so what would you?
Yeah, I would consider stopping and seeing if there's a different agent like azathioprine that they would respond to.
Thank you.
Thank you, Doctor.
Oh, and to that point, I was going to say, I do think that that is counseling, right? When a woman of that age goes on one of these drugs, to counsel them as well. You know, I think women of childbearing age are their own unique population with ITP, and there is a lot of discussion that can be had around how to do family planning with the different medications.
Thank you.
Thank you, Dr. Aditi. We also welcome our another guest from India, Dr. Ganesh Jaishetwar has also joined us from Yashoda Hospital, Hyderabad. Welcome. We now ask Dr. S.P. Verma for his question.
Very nice talk, ma'am. Just wanted to ask, like, if patient does not want to continue indefinitely and wants to, stop in due course of time, then what will be your tapering strategy in that case? Whether you want to reduce the dose from maybe 250 to 125 once a week, or you want to increase the duration from 7 days to 10 days, 15 days, like that, just to see how patient responds.
Yeah, so with Romiplostim being weekly, I think there's a lot of discussion. I personally do not abruptly discontinue. And I've seen the severe bleeding that can happen. I mean, I had a patient that usually had bruising. We stopped Romiplostim and he came in with hematuria, which he had never had before. So a new bleeding manifestation and more severe thrombocytopenia. So I sort of taper down. I do it, kind of maybe by 2 mics a week or whatever, and then kind of just see where the platelet count is, let them sit a little bit. With L-thrombopag, I have some patients where I have gone to like every other day. Like I've reduced them down to such a small dose that my next step is to go to every other day. And for some of them, I just leave them. Some patients are very happy on the lowest dose possible. Again, if the platelet count is 30,000, but that fits their lifestyle goal and they're on drug every other day, that works for me. I think we have room to sort of tinker with these drugs more than what the dosing guidelines from the clinical trials would tell us to do. But I'm in the taper category. I know there's people in the abrupt stopping. I think if you are going to abrupt stop and it's a patient that responds to steroids, having that on hand, making sure they have a dose of steroids at home that they can start if they have bleeding symptoms is probably also reasonable. And then I think we don't have as much data yet. There was some real world data, I think it was out of the UK, showing that some people did like every other week or every other. I typically just go down on the dose.
Thank you, ma'am. And just one more question, whether you want to keep them on regular weekly drug for a defined period of time, at least maybe for 4 or 6 months, something like that, minimum?
Yeah, I typically say to families, let's give this like a 6-month trial. I do a 3-month kind of big touch point at 3 months just to make sure that the drug isn't poorly tolerated or not working with their lifestyle, or that they're not, going into financial hardship over it. And then really 6 months is my benchmark of saying, okay, how indefinite do you want this therapy to be? Is it time to either think about a different therapy or think about how we're dosing this or things like that?
Thank you, ma'am.
Thank you, Dr. Verma. Dr. Ashish.
Thank you very much. I have a very practical question related to the uses that we came across in the beginning. Why do we need to start with 1 microgram per kg? Why can't we start with 10 microgram? Is it related to thrombotic risk, or is it related to headache that comes along? Because when we are looking at the vial, particularly for people with a lower weight, and initially only 250 mics was available for us, we ended up giving around 5 mics per kg right from the beginning, or giving even higher. So the question was mainly why to start? Why can't we get a faster response first and then reduce the dose?
I 100% support what you're doing. I think the reason we start at 1 mic is because, again, nobody's looked at the dosing outside of the clinical trials, right? And if you're the drug company, the last thing you want to do is start on a dose so high that you see side effects and get shut down, right? So of course they started at the safest, most conservative dose of 1 mic. I would say, at least in the ICON consortium, very few of us ever start at 1 mic. I mean, I will very easily, as you do, round up to a vial. I jump up very, very quickly. I've had some patients come in with severe bleeding that are refractory, and I hit them with 10 mics the minute they walk in because I want, they're bleeding. I think we can learn a little bit more. We still have a space of how to use this. Is there a role for the TPOs as kind of rescue medicine, right? We don't have a lot of options for a patient with severe bleeding, right? All of our focus so far has been discussing the platelet count, but we all know the patient that comes in with massive bleeding that doesn't respond to IVIG, that doesn't respond to steroids. All your other therapies are going to take weeks to start having an effect. What is the benefit of a hit of a 10 mic per kilo dose of romiplostim in that setting? Because even if the platelet count doesn't necessarily come right up, I do think there's value in stimulating the bone marrow for young, healthy platelet. And I see it. I see patients where the platelet count inks up just a little, but the IPF goes way up and their bleeding symptoms get better. So I think there is some value in just pumping out healthy platelets. So to your fact, 4 to 5, I think, is the average dose most patients end up with. So I'm very comfortable starting at around a 4 to 5. And again, I've really never had anybody overshoot right into that 400 range with doing that.
Right. I have another question related to the thrombotic risk. So our experience has been that the thrombotic risk maximum we see is when the platelets are just shooting up between 50,000 to 100,000. It's usually not there at the high level. Why we are so much worried about platelets crossing 4 lakhs? I mean, we can very well interrupt for a cost effectiveness and to reduce. Is it really thrombogenic that much if it is crossing 4 lakhs?
I don't know. I don't think anybody knows, right? I mean, again, I think the company was sort of saying, okay, we don't want you outside the range of normal, right? Again, we don't want to take that risk on. And I agree, like being outside the range of normal was probably in study design the appropriate cutoff, right? As opposed to something more arbitrary. You're absolutely correct that what everybody sees in clinical practice and what's reported in the data is no correlation between height of platelet count and the thrombotic events. So I think, when I almost say that adjusting romiplostim to me is almost how I adjust Coumadin. And I know my patient and I know whether I should follow the nomogram or I know whether I should do my own thing. You get to kind of know the patient's own pattern with the drug. And I have some patients that might come in at 425, but I know if I so much as go down by 1 mic, the next week they're going to come in. It's like, it can be just as twitchy as Coumadin, right? There's some patients that their INR is 6, they don't bleed. You kind of just maybe tweak it a little. It's not as straightforward as just 1 nomogram for every patient. I don't believe that's true.
Thank you.
Thank you, Ashish. Dinesh?
Am I audible?
Yes.
Yes. Yes.
Okay. I was just asking because now it's become a kind of a second line. Do we have some trials adding a drug? So not only the Romiplostim or TPA along with this, and then you can stop a TPA and continue the another drug. Because many patients are not comfortable continuing for many years, considering you're using them in the early phase of the treatment, whether we add on some drug along with this and stop this and continue the other drug. Is there any way, any thinking about this?
Yeah, I mean, it's interesting. Again, I always give my patients the option to not stay on. And I think that's the danger in drugs like TPOs, right? As you put them on and it's easy to lose track of the time. And I think it's important when you start to set time points, right? We're going to touch base every 3 months, every whatever, not just the day-to-day dose adjustments and your platelet count is fine, but really, truly, is this still the right drug? And I think it's very safe to add in other drugs. I've added in immunosuppressive drugs. I've switched patients over to rituximab when they've said, I just don't want to stay on drug anymore. I want something that might give me a more durable drug-free response. It's interesting, to your other point, I think a little bit, we don't know really if there's benefit in earlier use. There is some suggestion that the earlier we use these drugs, those are the patients that might hit that kind of remission, right? Is there benefit? We're looking at a pediatric trial of using L-thrombopag up front. There's been work in using L-thrombopag and TPOs up front in adults with ITP, mostly to see if we can get better remission rates and not have to go to other second-line therapies. But I think, it's important to listen to a patient, and if they're saying, I don't want to be on this drug indefinitely, I think it's safe. I think we have good 5-year data showing no increased safety signals in these drugs, but I think we have to really value the patient preference and not be afraid to switch over. And I've had some patients where I've left them on Romiplostim to bridge them until starting whatever other agent is going to kick in, whether it's MMF for some patients for me, it's like sirolimus or whatever I'm going to do next. And I just leave them on the TPO until that picks up. We know that there are patients that don't respond to a TPO, don't respond to MMF, but somehow respond to the combination as well, right? So there's some synergy there, but that tells me it's safe to use them both, right? You can overlap them if you have a patient that you really want to bridge onto a different therapy.
Thank you.
Thank you, Dinesh. Dr. Amita?
Yeah, thank you so much. It was a very interesting section, like Dr. Agarwal said, especially the chemotherapy-induced thrombocytopenias. I have two quick questions. In the post-bone marrow transplant settings, a number of people have used it when there is delayed platelet engraftment. But has it been evaluated in this phase preemptively to see if we can actually get, early prompt engraftment, because that seems to be kind of a logical step forward. The second one was the place where we really struggle with chemotherapy-induced thrombocytopenia is in acute myeloid leukemia. And again, has there been any analysis in that space, if not in induction, at least in consolidation, whether we can reduce, platelet transfusion need?
Yeah, so to the first question, the bone marrow engraftment is a really interesting question. I don't know that anybody's used it to enhance engraftment. We certainly use it in the patients that have really delayed engraftment, right? But to your point, that might be too late. Like that might not be where we want to use it. And also, what could we gain if we used it earlier and avoided all of the transfusions, bleeding episodes?
We need to try lineage hematopoiesis, not just the platelets,
exactly.
Just the aplastic anemia.
Because we know it drives that in the aplastic anemia population. We know there's some driver beyond just platelets. So I don't know that anybody's looked at it in the bone marrow transplant space in that realm. I do know there's been small reports of kind of using it with your platelet refractory patients, delayed engraftment, those sorts of settings, and that's typically how we're using it. To the second point, I'd have to go back. I don't think that in the Al-Samkari paper is probably the largest adult paper looking at heme malignancies. And I don't know that they specifically parsed out AML or ALL or which group. And they probably didn't, because they probably didn't have enough of any one group of patients to do so. But I agree with you, the AML patients that sort of have to stay in the hospital just because they're needing, their transfusion burden is so high. Again, are really another good space. I think as we get more comfortable with losing the narrative that we're going to somehow push clonal evolution, I don't see a reason why we shouldn't use these, right? I mean, we use GCSF very comfortably, once we really fully got rid of the notion that we're going to somehow cause clonal evolution. And I think our MDS data is starting to support that. And the aplastic data, right, as these drugs get used more and more in the aplastic setting, two settings in which, chances for clonal evolution are certainly there. So yeah, I think that there is a role in the chemotherapy-induced space for these drugs. It's interesting to me that they weren't able to find positive clinical results, right? It seems so intuitive that you would have reduction in transfusions, reduction in days with thrombocytopenia, ability to pursue more aggressive chemotherapy. I'm shocked that the systematic review really didn't find that. I did appreciate that the authors were like, we're not giving up on this, right? Like there's still enough positive trial results in these papers. And likely it's just how heterogeneous the studies were that it's hard to find the right signal. So I was really happy that the take home of the paper was not, we shouldn't do this. It was, okay, we just need to study it a different way. That's always a pleasant take home message. More work for us to do. And I always love it when we're not giving up on things because it's just so intuitive that this would be of benefit to patients.
Thank you. Thank you.
Thank you, Dr. Amita. A few questions from the audience. There are a good number of them who have logged in from over 20 countries today. Is there a role of Romiplostim in sepsis-induced severe thrombocytopenia?
That is a great question. We had talked about that. So I do some work in Cambodia, and I did find one paper in dengue fever, which is one which has a huge amount of thrombocytopenia. And we sort of talked about it. Again, it's kind of that cost approach, it came down to cost approach, but talk about another condition in which if you could show some stimulation of platelets, wouldn't that be amazing if you could get through that huge, risk? So I think it comes down to, the actual individual condition, the risk of bleeding in that condition, how to offset the cost. I'm not sure that there's been a huge amount of work done yet for use of this in DIC. Again, the concern might be, DIC, you've got kind of an imbalance, you've got a balanced state, right? Where you're walking that fine line of bleeding and clotting, and is something going to push it in the wrong direction, and the TPOs may not be favorable there. But just if it's the thrombocytopenia piece without DIC, then perhaps, and with a huge hemorrhagic component, there would be benefit.
Thank you. Another question is whether you can give Romiplostim and filgrastim together.
Romiplostim and which one?
Filgrastim, GCSF.
Oh, fascinating. I have a case report of an N of 1 that just happened to me. I had a girl with Evans syndrome. I had her on end plate for her ITP. She was plodding along at like 60,000 platelets, finally got up to about 100,000, but then got really significant autoimmune neutropenia, was actually having some mouth sores. I gave her a dose of GCSF. Her platelet count went up to 1 million, and her GCSF, her ANC responded. She's very exquisitely sensitive to the GCSF with her ANC. I would be cautious. And this is again with the chemotherapy space, right? But they didn't report in any of these trials, they did not report significant thrombocytosis. Again, I don't know how many patients were getting GCSF as well. And when I talked to Kay Armstrong, the person who did her research paper, she hadn't seen this. But my patient came in and freaked me out with like a platelet count of 1 million one day after 1 dose of GCSF, while also still staying on her weekly end plate. So a little bit traumatizing to me, but again, it's just one patient. The literature out there is using it in chemotherapy-induced thrombocytopenia, and they're not reporting these extreme, K holds for over 400,000. That was in her sarcoma patients who are also, getting GCSF exposure and didn't see it. So maybe it's different in a chemotherapy patient than it is in somebody with the immune process, right? I mean, you're dealing with a very different bone marrow. I would be reluctant to say do it in the ITP Evans syndrome setting based on my one patient. I was like, and now we've got her just on GCSF because the neutropenia is the bigger struggle. I took away her end plate, and the GCSF is actually maintaining her platelet count too at a good level. So, these drivers of precursors are all kind of interacting, right?
Right. I have a couple of questions for you. Is there any data on using more than 10 microgram in ITP? Like, aplastic and MDS, we use higher doses?
Not that I'm aware of. When we did our retrospective study, we had 1 or 2 patients that got, there was maybe one patient that went as high as 11 mics. That was it, like out of the whole 70 patients. So I'm not aware of people. I think the thought is if you're on the max dose, you've been on it for 4 weeks and you're not responding, you're just kind of a non-responder. I'm not aware of people pushing the dose much higher. I'm sure people do it, but it's not a reported thing.
Right. If you're switching from one TPO RA to another one, do you overlap or you can just discontinue one and start the other one?
So I overlap. I know it's going to take time for the second drug, you know, depending on which direction I'm going. If I'm going from Romiplostim to L-thrombopag, I will keep the Romiplostim going weekly while starting the L-thrombopag. If I'm going in the other direction, I'll give the dose of Romiplostim and maybe do another week and kind of see where we are. So I overlap a little bit. And it kind of also depends on what I know about how sensitive they are to dose changes and things like that.
Sure. In an acute ITP, is it you did mention a couple of times that those trials are going on. Is it a good idea to start with both steroid and TPO-RA?
So I think in the adult population, yes, right? I think in adult patients, I've had these conversations. And I have to say, I know the adults are very reluctant to get rid of steroids up front. It would be lovely to find something that could be steroid sparing in adults. I think the concern is you still need that immune modulation of steroids to get the remission, right? So different than pediatrics. In pediatrics, we actually did design our trial so that patients either got randomized to standard of care or just a TPO. But we're different in how we practice in theory, right? So in the pediatric space, I think it's, can we show that these drugs have benefit in the newly diagnosed patient? For adult patients, the question is, does augmenting and providing that antigenic stimulus while still providing immune suppression in the background get you better remission rates?
Okay. One last question I have is about congenital thrombocytopenias. And like Viscott, Eldridge, etc., as a bridge to transplant, you can buy time by giving these drugs. They can keep the platelet up. So do we know that which genetic thrombocytopenias they work and which one they don't work?
No, I think unfortunately, because they're such a rare population, there is an open kind of registry, and there's some guidance on this. But again, they all get lumped together because they're so rare that it's sort of there. I don't think we're ever going to find a group of enough Wiscott patients to know which Wiscott patients we should or shouldn't be using this on. I think the message is that they're of value, and it's just when to start them, which patients. They're always so challenging because some of them can be fine, and then it's one event that makes them not fine, right? But no, I think it's an interesting group. I don't think we'll ever parse them out to any specificity just because of how rare they are, but I do think it's another group that merits thinking about how to use them.
Thank you. If there are any questions from the faculty here.
Good evening, sir. Just one question, Dr. Ganesh.
Yes.
So, great talk, madam, and a very interesting discussion. I'm sure all of us have so many burning questions, but time limitation. So, madam, many a times we have patients who are refractory to either L-thrombopag or Romiplostim alone. So, is there any data of combining them together, because both of them do work differently, have a different mechanism of action? So, what is your opinion, and have you used both of them?
Yeah. So I've never used both of them together. I have done the background of immunosuppression, using them with like either MMF or sirolimus, or even just a very, very tiny dose of corticosteroids. I don't have personal experience using them together. I know people have tried it. To me, I like the idea of a little bit of immunosuppression as opposed to two things on the same pathway. it makes a little bit more sense to me to add in a second pathway to get more benefit. So my approach is typically to add in then something in the immunosuppressive category. The other thing I have seen is some patients do much better with avatrombopag, particularly going from avatrombopag from L-thrombopag, just because L-thrombopag is very fussy with the diet and how you have to take it.
So, and just if I'm allowed, sir, another last question. So just the way TPO analogs works. So the another, the conventional traditional agent, I will say, which we have been using for years and decades now, dapsone. So is it logical? Because for us, the patients, the questions from the patients is how long I'm going to continue these drugs. So 6 months, 1 year, after 1 year, they get fed up. So is it logical to switch over, like overlap and then gradually take Romiplostim off and continue dapsone? Because in a way it works the same way.
Yeah, no, I think it's, listen, I think it's very reasonable for us to, I always tell patients, I'm like, I have a toolbox of things I can use to treat your ITP. We can switch around within that, right? And particularly if a goal changes or their needs change, or as you said, their concerns change or whatever it is they want. Some patients, we ultimately go to rituximab, right? Because they want to see if there is a drug that they can get that would take them off of a need for ongoing medication. I think that's when we did the guidelines, we spent a lot of time talking about rituximab because we had two camps, right? We had people that said, oh, but you can be on a TPO forever and your platelet count does great. We know rituximab relapse rates are really high. But if you think about it, like perhaps there's benefit, even if patients relapse 2 years after getting rituximab, they still went 2 years without being on a drug. And that might really be of value to a lot of patients, right? Is time gained without drug. So I really think very clearly, mix them up,
Thank you so much.
Thank you, Ganesh. Aditi?
Ma'am, there is one case with us, which I also presented, young girl, 14-year-old, refractory to multiple lines of therapy, which includes steroid, rituximab, MMF, dapsone, and romiplostim, and even splenectomy now. We have done her primary immunodeficiency workup, autoimmune workup, and even NGS, which is all normal. So have you seen any such patient, and what would you advise? Is there anything extra that we can add for her?
So she's had, remind me again, what has she had so far? She's had
steroids, MMF, dapsone, rituximab, and romiplostim, and recently 2 weeks back, splenectomy. Day one of splenectomy, 80,000. 1 week after splenectomy, 10,000 platelet count.
Oh, these patients break my heart. These are the challenging patients. One thing I always do in these patients is very specifically look to make sure I'm not missing an immune deficiency. So these are my patients that I might screen with like a genetic panel. There's one through the company Invitae, but there's, looking for any sort of primary immune deficiency, because I tend to think these highly refractory patients are the ones where there just has to be some immune dysregulation, right, that's occurring. The drug that seems to be entering into this space is sirolimus. And there's a really nice paper by Michelle Lambert and David Tichy out of Children's Hospital of Philadelphia outlining their protocol. Because for these patients that have this immune dysregulation, sirolimus kind of targets a different compartment altogether and is kind of growing into that space.
Okay. We had done her clinical exome study, ma'am. It was normal. So we will add sirolimus and see now.
Try it. I mean, I have a similar patient, and we finally just, we've all accepted that she just lives with a low platelet count, and we're all just thankful that she doesn't bleed. And mom said she really doesn't want to try to experiment anymore with more medicine. So, I mean, sometimes that's where we end up. I often sometimes say it's okay for us to take a little, I call it the drug holiday. I said, do you just need a drug holiday? Let's just see how you do living without medicine and living with your ITP. Can't do that so much in patients that we know every time the platelet count goes low, they have significant bleeding. Those are the trickier ones. But I mean, you've done everything that's, but I would say sirolimus is probably the only other thing, or trying something in combination, right? Like a TPO alongside of immunosuppression.
Right. Yes, ma'am. Thank you.
Thank you, Dr. Aditi. I don't see any other hand raised sign. Do you have any question, anybody? If none, then before I hand over to Alkem, on my behalf, I thank Dr. Cindy Nunert and all the faculty members present over here to make this such a fruitful and educative exercise. Dr. Cindy Nunert has been our great friend. She has been with us at multiple occasions, sometimes at short interval of every 3 months and 6 months. And she has educated so many people in this part of the world. Today also, we have got audience from almost 20 countries. And I'm sure that this will benefit their patients a great deal.
Always a pleasure.
Thank you.
Always a pleasure. You all have a lovely evening.
Thank you. Hand over to Alkem for the vote of thanks.
Thank you so much, Dr. Vaughan sir. So it was indeed a very, very enriching session, and I would like to thank Dr. Sydney Nunert for the same, and Dr. MB Agarwal sir for moderating the entire session so beautifully. Not only these two doctors, I would like to thank each and every discussant, Dr. Ashish sir, Dr. Kanish sir, Dr. Purani sir, as well as all the budding oncologist panelists to give such an enriching talk on the Romiplostim and its advances and what is the current scenario right now going on. Apart from this, I would like to thank each and every audience who has taken their time out to reach out to us and to have this enriching talk from Dr. Sydney Nunert and MB Agarwal sir. Apart from this, I would like to thank Mr. Kalpesh from Square to conducting this on a technological platform without any glitch. So thank you so much, Mr. Kalpesh. And lastly, but not the least, Mr. Abhishek sir, the business head of Alkem Oncology, to give opportunity to conduct such a nice meeting and to get us all together to discuss on the product, on the molecule Romiplostim and its advances. So again, I would like to thank each and everyone to be part of this. And I wish ma'am a very good morning and everyone a very good night. Thank you so much. Good night.